say welcome to everyone for our Wednesday, June 19th, 2019 Mastermind. Particularly excited about having Dr. Joy Boyd Holmes to present with us today. Now, remember, masterminds are a think tank, so you can, as long as we're not getting any kind of cross noise or whatever, you want to leave your microphone open. You don't have to write in the chat box. If you have a question, if you have a concern, you have something to say, please share it with all of us. I know Joy particularly wants to engender discussion on this very, very important subject of calibration. Of course, you do get a 1-hour CE credit for it through my PACE AGD program. In order to do that, we have 2 parts to qualify. One is a course description, and all you need to do is put your full name, first and last, in the chat box. But I'm going to go through the names here because Patty Beeson is also got my master list for attendance that I need to keep for the for AGD. So is Angela here yet? No. Carol? Not yet. Cheryl from Hawaii isn't here yet either. Connie Simmons just contacted me, and they are in flood. They're in a flood. She just said that.
Oh no!
Was the last one. Yeah, they're in trouble. They're having big rain, 2 feet of water in the streets. So she's going to high ground.
Oh my goodness! Yeah, she reached out to me yesterday.
Yeah, it's crazy. So Eileen, are you here? Not yet. Eileen Prizzi is our newest member. She joined today after we had a call. She's a friend of and has worked with our friend Melissa Braca, so it's awesome. She has a whole lot of background in the insurance world as well as being the clinician, as well as in HR, as well as. Jean Wynn, say hi, Jean.
Hello.
And of course, Joy is here. We'll get to hear from Joy. We hope, because I don't know her slides. Oh, Karen, are you here yet? Karen Jordan? No. Catherine.
Hello.
There she is. Kimberly, I don't see Kimberly here yet. Linda Jorgensen? Not yet. Lucy?
Yep, I'm here. Hello.
There's Wisconsin. There we go. How about Michelle? Are you here? Michelle was trying to stay awake long enough, but she also is out on the East Coast. So who knows? Say hi, Natalie.
Hi, everyone.
There you go. Thank you. Paige she's coming in from, again, Paige is out in the Seattle area, so she's going to get here as soon as she can after work. Pam, are you here? Not yet. Patty B, say hi.
Hi.
Here we go. Renee Johnson, I don't see her yet. Rhoda, not yet. Susie, not yet. But we do have our Teresas. So, hey, say hi, Teresa. Seaman.
Hi.
There we go. And Teresa Shepard.
Good evening.
And no group is complete without having 3 Patties. So, Patty Korecki.
Hello.
Hello. Is there anybody here that's on the call and is not showing up on the board? Again, put your name in, let us know you're here. So moving forward, I announced we had last month our first Smart Bulletin versus a newsletter, and I've got some unbelievable stuff coming for you this month on questions. It's a combination of questions that I get. Although, Teresa, we should probably write up something on what we just talked about. But anyway, questions that I get as well as just some other really smart news. So that will be coming out. That comes out the 4th Monday of every month, and so that'll be out next Monday. Last night, this is for some of us, and I thank all of you that did this 2 nights in a row to be on a meeting. I'm not quite sure how I scheduled that, but we are moving forward with, I didn't change the slide. We're moving forward with our submissions for next year, and we have 48 people that stepped up to participate in our different work groups. So thank all of you that did that. But even if you haven't got a chance to be on a work group, I will still take volunteers. always they're part of the DCC, and our next meeting is on Sunday, the 14th of July. This is the people these are the liaisons and the group leaders for the implant maintenance in biofilm is Melissa. Remove the provider language, Patty Korecki. More Profi codes, Tasha Bates. Oral cancer group is Susan Cotton, as well as the non-therapeutic, actually I'm starting to call this the opioid vaping group. Not that they use opioids and vape. That's none of my business if they do. Anyway. So these are our leaders, and we really appreciate it, but we're all leisure. I see Renee has arrived. Hi, Renee. Also, exciting news that we are now having the pieces and parts together, that on Friday, if you're going to RDH Under One Roof in Texas in late July, early August, we are going to have an insiders meetup. This time we're calling it Leading with Kindness, because we're doing this in conjunction with a couple of other dental hygiene and women entrepreneurs, and we're really excited about it. So if you're going to be there, save the date. You will be getting the e-bite and more details on that as soon as they send the contract back, right, Patty?
Yes, exactly. With the right name on it, and the fact that
with
I'm
the
not
right name on it. Right. Although if that Canadian wants to pay for it, I'm good. I have no idea. So I also just saw, by the way, the calendar. This calendar online is getting more and more robust all the time. I want all of you to really encourage you to start using this dental codology website. This is insider content. Only you guys have access to this. Other people don't. And there's some blogs that go here, and even from the newsletter, they only go here. They don't go to everybody else. These masterminds, I get those turned around, and they're online within just a day or so. What is also happening is we are now, if you're here live, you get a CE. But if you miss one, there are CE quizzes that are on here, so you can go back and do those. In addition, our consortium is the work groups. We're going to have everybody, it's all going to be here. So even if you're not on a work group, you can come in here and look. This is last night's meeting and what we talked about, and to how we are setting up the groups and all that. And then there's a lot of things here. Now, what I brought you over here for is to see the events. In the events calendar, what we have is you can just come in here and just hover over, and so you get all of the information about what the course is going to be. Which really brings me to my next thing, which is the calendar. And okay, what did I do? Talking about the next month. And Liz, I saw you came on. Say hi, Liz. Liz Neese,
Hi.
I saw you come.
Hi.
There she is. If you don't know Liz Neese, she is the absolute most serious. She never cracks a smile or has any fun. Oh my God, she's a wackadoodle. She's a great friend. She's going to be leading our mastermind next month on Oxygen is the Key. Liz has done a real lot in dentistry, including hygiene consulting, and she has been working with Perio Protect, and she's an amazing expert. So next month, that's on Tuesday, the 23rd of July. So you have all that on your calendar too. So let's go. Let's get Joy going here. Again, the CE certificates are already ready. In order to get the CE, put your first name and last name in the chat box. Now, Joy said, oh, I hate talking about myself. So I'm going to read what all of these letters, and Natalie, someday we're going to have you do a mastermind just so we can put all your letters up there. Plus, you're amazing. So insiders, Joy, Dr. Joy D. Voigt Holmes, RDH, BSDH, MHSC, AADH, is the founder of Dr. Joy RDH and the creator of Dental Hygiene Student Planner. She's been in the dental field for over 27 years, 20 of those as a highly engaged, well-known RDH in the Washington metropolitan area. She's currently part-time faculty at Fortis College in Landover, Maryland, where she teaches preclinical instrumentation, nutrition, and biochemistry, community health, and process of care. Joy also serves as a consultant examiner for the CDCA, CRTA and the CITA examination boards. Oh, wow, we were just talking about boards. Dr. Joy is a member of the American Dental Hygienists Association, the American Academy of Oral Systemic Health, the Association for Interdisciplinary Doctors of Health Science, the American Dental Education Association, the American Dental Hygienists Association, oh, I said the other one wrong, the Maryland Dental Action Coalition, and the Maryland Dental Hygienists Association, where she serves as president-elect. Dr. Joy is also a key opinion leader for Parkel. I had the joy of meeting Joy in person when I spoke in Virginia earlier this year, and she's absolutely amazing. And I want to hand things off for her because this idea of calibration, Patty, you've heard me talk about that about 100,000 times. I talk about it every course, the importance of calibration. Otherwise, our patients are so confused. So, Joy, take it away.
Well, welcome everybody. Thank you for joining us tonight. As Patty stated earlier, because of this topic and the nature of the topic, I want to hear others' opinions. I think it's very important that we stay engaged with this. Calibration, of course, requires us to kind of be on the same page. So I think it'll be a good idea. You're going to hear me stop a few times throughout the presentation and really ask for your opinion. So I hope you don't mind, and I hope you're ready to share. Next slide, Patty. So here are some of our objectives. I'll go through them really quick. So what we want to do tonight is get an understanding of the basics of calibration, be able to discover ways that calibration will lead to clinical consistency. Further, we want to be able to discuss methods for successful calibration sessions, and create a calibration protocol for your dental team. Next slide. So this is going to be my first question to you. I would like to know, what is the first word that comes to your mind when you think of the word calibration? And I want to hear you talk. I don't really want you to type, if you don't mind.
And Joy, I will help facilitate because I'll call on these people because I know them all.
Okay.
Somebody want to have what's calibration, guys? What do you think of when that word comes up?
Machine.
Something mechanical.
Wait, one at a time. Who was it?
Something mechanical.
Okay. Mechanical.
Okay.
Consistency. Consistency.
Consistency.
I like that one. I like both of those, actually. Okay, well, thank you for sharing. Next
Similarity.
Yes.
Yes.
Yes. Next slide, Hattie. So what it means to calibrate is relatively simple, actually. So when we calibrate, we are using methods to achieve standardization, meaning we're doing the same thing the same way each time. It is also a way to maintain consistency in patient care. And I will tell you, a lot of the times, or some of the times when your patients are upset or frustrated, it could be because of lack of calibration. Maybe you said one thing, the assistant said something else, then the person at the front desk said something different, and then we have the hygienist saying something different. So that could be very confusing to a patient. But last, it allows us to apply consistent techniques and philosophies in the dental practice. Next slide. So what are the implications of calibration? So you have positive and negative impacts. So some of the negative implications of calibration, again, you get that frustrated and confused patient. You have the he said, she said, and it's just, I can't tell you how many times I've seen a patient either walk out or refuse treatment because we aren't on the same page. When you're not calibrated in the clinic, you get variance in patient care. So for me, I've worked in an office, 17 operatories, where there were 5 different dentists and 4 different hygienists. And it wasn't uncommon for us to share patients sometimes. And I've heard patients say, well, she didn't do it this way. Well, she said we were going to do it this way. So it becomes very, very frustrating, not just for the patient, but also for the clinician. Another negative implication is you have decreased patient satisfaction and your patients don't trust you. I think another one of the negative implications of a lack of a calibrated staff is that you get dissent amongst the staff. So it creates this hostile environment depending on how bad the calibration is. But on the flip side, there are positive outcomes when you have a well-calibrated staff. So you have uniformity in patient care in the office. There's transparency that is created in the delivery of care, and that's going to be key. It helps to bolster patient satisfaction. And to me, I think this is probably one of the more important factors, is that it fosters a team approach to patient care. Again, everyone is on the same page, and that ultimately leads to a positive work environment. Next slide.
Before we go to the next slide, can I ask, I don't know if you ask a question, calibration, ask a question or just cause some trouble. I think it might be second. But one of the things that I see, and I think many of us experienced, is when there's a consultant that comes in that basically wants everybody to do the same thing. And rather than what I think of as calibration, it becomes cookie cutter approach. And that's not what you're talking about here. Am I right?
No. You're absolutely correct. That is not what I'm talking about. So we know in dental hygiene, in dentistry in general, and let's just take it a step further and say medicine, there's no true black or white, there's shades of gray because everyone is different. And we always want to cater our care to the individual. So where you may have standards, your standards would be where you're calibrated, but how you apply those standards is going to be different for each and every patient. And so I've worked with consultants before, and I think the consultants who don't have a clue about clinical care want you to apply this cookie cutter approach. And it just, to me, it doesn't work, and it becomes very, very frustrating. I would like to hear someone else's opinion. Anyone have you dealt with a consultant who wanted you to apply this cookie cutter approach?
Come on, guys. Okay, Liz, are you there, Liz?
I'm here.
You've done hygiene consulting. Come on, jump in here on something.
Well, I think the hardest thing is that, standardizing what is healthy to everybody and having, I'm not a cookie cutter approach. So I think having your standards is really important, and that everybody bases their treatment plan on those standards and what the risk factors are for that patient.
Yeah, I like that. I think that's very important. Next slide.
Jean, can I ask you, have you had, in the many years that you've been practicing, have you had consultants in your practices?
No, we have not. We have, I work for a group practice. We have 8 hygienists and 3 doctors. We all probably, I see variations in maybe the approach to like probing. If you're talking about probing, like doing a perio chart, so we're all a little different, I think, in how we interpret things.
Has that ever caused any confusion with your patient?
I think so. And even within the doctor, among the doctors, there's variation. There. So just their
understood
interpretation, their approach, their maybe reluctance to refer when they probably should, or do some maybe like for scaling and root planing, maybe instead of just kind of seeing them more frequently or whatever, and trying to play catch up and not having a plan is frustrating for me.
Absolutely. No, absolutely. I could see where it would be frustrating, especially in a practice that large. One thing I want to comment on, though, is I think sometimes, and even in the educational setting, because I do calibration for schools, which is similar but different, is that calibration is not just how we do things, but is also what we say in our thought processes. And I don't think enough attention is paid to that aspect of it. People really focus on the technical aspect, but we have to think more along the lines of what we say, the cognitive aspects and theories of that nature. And there's really not a lot of research out there, believe it or not, regarding this aspect of calibration.
Another thing too, I know my experience has been with lots of temping and a lot of other things, is that, you know, I feel like you can go to 10 different doctors and get 10 different diagnosis and treatment plans. And sometimes 3 of those doctors are in the same practice. Okay. And let's just call it as a lot of us have experienced it. Natalie, from the assistant's perspective that you have lived all these years, what do you have to say about this?
There is a lot of difference between providers. A lot of it is where they were trained, if they've done residencies, where the residencies were done, whether it was on the West Coast, the East Coast. I mean, you see vast differences. Also, the approach to how conservative or aggressive they are in treatment planning.
Yeah.
And what makes me wonder are there firm, this is where it's at with health or not health? You know, I mean, because it's so varied, there's so much variety. Is it art and science? Is it that some people just don't know? Or the standards are so low?
I think that people just don't think it's important. I really don't think people think it's important. And again, I'm going to always go back to the educational standpoint and to the point, you know, it really depends on where you were trained and how you were trained. And it's not about my way is better or your way is better. It's, if we're going to be in the same office, how do we come up with a way that we both agree on that's beneficial to all parties involved? And I just, again, I think there's a lot of ego involved. So people just don't want to make time to sit down and discuss their differences. But I think sometimes people are more similar than they are different. But if they were just to make time to get on the same page, I think that they would see better outcomes all around.
Yeah, for sure.
Okay, we can move on to the next slide. Okay, so I have a question. Does your office have a clinic practice philosophy?
Kimberly? Since you haven't even said hi yet, I thought I'd call on you.
Hi. Well,
Hi.
you know, it's chaotic here because my sister-in-law had a baby, so it's 8 days old. So it's my first time coming over. So my brother and my sister-in-law are also hygienists.
Oh, wow.
Oh, wow.
Yeah. But my office does not have a practice philosophy. I don't really have it.
Okay. Well,
can I throw something in? Because I did a program last week at I'm not sure what is the line between what is a group practice and what is a DSO, and I think that's a moving target, but it was a family-owned six practice group that were from central Indiana. And when I was, my program was from 10:30 to 12:30, but their event started at 8 a.m. They first started with a prayer, and then they started with their mission and philosophy statement. They had the 5 leaders of the practice talk about what was their definition of, the various words. And then they went into an exercise where they broke the offices down and into their individual offices and said, can you come up with something that is showing how you're manifesting that in your office? So it was, now I've had that experience before in a practice that I worked in, but it was really interesting with this was their day of bringing everybody together in education, and that's what they started with.
That's interesting. That really is. And I think practices that have a clinical philosophy or clinic practice philosophy in place, I think that's one step further to having them calibrated. Because what your clinic practice philosophy will do is serve as a guide. And depending on how detailed it is, it will be a document or a guide, a manual. It will be something that you refer to when you recommend treatment, when you're scheduling patients. It will have your infection control policy. So essentially, it is your overall guide for the office. So let's just say someone needs a needle stick. All offices should have a needle stick policy. I think that is something that, whether you know where it is or not, if you were to get a needle stick, hopefully you have a policy. And if 5 people get stuck by a needle in the office, it's going to be the same procedure on how to go from the time that you get stuck until the time that you get treated and the follow-up. So this clinic practice philosophy, it does take time to develop, but I think that offices will find with this in place. I don't think anybody will be 100% calibrated, but I think that it will help offices to be more calibrated if they have one. Next slide. Okay. My question to you is, do you think this guide is important for your office? Because that's going to be key. We have to have buy-in. And I just want your honest opinion. Do you think that this is something that would be useful? Do you think it's important? Is it beneficial? Do you think it would help to calibrate your office?
I think every office should be calibrated with philosophy, you know, how you're going to speak to patients, you know, what's your policy if the patient comes 10 minutes late? What's the policy if somebody's running behind? What's the, you know, to avoid conflict and for everybody to be on the same page, I think you really do have to be calibrated.
Yes. And Liz, you said something that I really would want to focus on, is that how do we speak to our patients? How do we speak to our patients? Again, it's not just about what we're physically doing, but how are we talking to our patients? So thank you for sharing that. I think that's very important.
One thing that I'm taking away from this in terms of comparison is I teach risk management. And so this isn't just about clinical. When you have your clinical protocol in place, your risk management program falls into place.
Mm-hmm. Mm-hmm.
And Teresa, your background on that is?
Well, I've been teaching risk management for probably about 10 years now. As a registered dental assistant, I still hold that. And then admin for 25 years. And then I just kind of self-taught in terms of what I needed to know when I needed to know it, because we didn't have any access. So we had to learn ourselves. And it just evolved from there. And I love that. I love teaching that.
And it's something you also, it's a service you provide to offices, because that's when you contacted me about that pattern you noticed about radiographs. Tell that story, because I think it has some real value here.
Well, I do a little program called Snapshots Prevent Mugshots, and I just kind of go in and do a little virtual check around on different things. So I see a real consistency when I do that of just x-rays being routine and not clinical based, but as well as they're not diagnostic. They're miscoded terribly. We're still seeing a lot of 4-bite wings in a pano as an FMX. Nobody understands.
Oh, wow.
And so it puts the practice at risk. So part of calibrating, it would be pulling both of those aspects together.
Mm-hmm.
At one point, Teresa contacted me too, because she goes, I know the answer to this, but I want to make sure that that I'm just, because sometimes you do need to have somebody else to talk to. And what she was telling me that she saw was a pattern within a couple of offices that had purchased this, a high-level CBT machine that you can take a pan that's good enough and that can take it to such a high level of quality and detail that they can extract a set of bite wings out of that. And what you noticed was that they were charging out both the Panorex and the bite wings, even though it was only one image. And she said, "Is that?" Yeah. And when she tracked it down to the person that sold them the machine said that they can do that. Now, problems on all kinds of levels here is that they were told by somebody that to do something that's fraudulent. Now, I don't think there was a negative intent by that person. That person, they wanted to sell the unit. We understand that. But that person, what is their knowledge? And this goes back to really what this whole dental codology is all about. It's about codes, and it's about how the misinformation that's out there, and unintentional fraud is still fraud.
Yeah.
And that goes to the calibration aspect of this too. Is
Right.
that, yeah.
Exactly.
So.
The rep isn't going to discuss codes necessarily. That's not their selling point. Their selling point is convenience.
Yeah.
Yeah.
Absolutely. So who ultimately, in your opinion, benefits in a clinical setting from calibration? Who benefits the most?
The patient.
Absolutely. You hit the nail right on the head. The patient. Next slide, please, Patty. Okay. So I like to do this comparison. In an educational setting, it is the student who benefits the most when faculty are calibrated. And if you are someone who goes from an educational setting to a clinical setting, or even as a student, if you remember how frustrating it was when your faculty wasn't calibrated, put yourself in your patient's shoes. In private practice, we calibrate for the benefit of the patient. First and foremost, for the benefit of the patient. And then second, I feel that we benefit for ourselves, the staff. In an educational setting, we have standards that are typically determined by CODA and from an infection control standpoint, CDCA and OSAP. But for practitioners, we also have those standards. We do follow CDC standards and OSAP, but we are also governed by a higher body, and that is our code of ethics. And believe it or not, if practitioners were to remember that code of ethics, that would be a way to calibrate the faculty. Next slide. So there are several barriers to calibration. One would be emotional responses. And by that, I mean, you get together, you're in a group, you're having your morning huddle or your monthly office meeting. And what's one procedure you would say that no one ever really agrees on? I would say when to refer to a periodontist or when to keep in-house. And you have an hygienist who's fresh out of school and they were taught, anything above 6 or 7 millimeters, you should refer out. And then you have the old school dentist who wants to keep everything in-house. And so you have two people butting heads, and that doesn't always go, things don't always go according to plan. So that could be a barrier. You have two people who are very emotional. And when people are emotional, communication gets lost. So that could be a real barrier to calibration. Another barrier is differences in diagnostic vision. So you have a group of dentists, you have your old school versus your new school, and how should we be diagnosing? I think someone said earlier, you have practitioners who are very, very aggressive in their treatment planning. And then you have those who are much more conservative. I know over the weekend, I was at a tournament for my son, and I had one of the parents come up to me, and she said to me, I think I have a case of medical malpractice. What should I do? And so she starts explaining how she's been to this dentist several times. Every 3 months she goes, and it seems like the dentist is always finding something. The last time she went to this dentist, the dentist told her she had 4 cavities. And she's like, well, how do I have 4 cavities? I'm coming to you faithfully. So she left and she went to another dentist who didn't see the same thing. So she then says her friend goes to the dentist with her 2 kids. And once again, this dentist is diagnosing her kids with multiple cavities. She suggested that her friend take her kids someplace different, and the other dentist didn't find anything. So I probed a little further. I asked the dentist's name, and I'm thinking, okay, I know this person. Let me make a phone call. And what I'm finding, actually, I called a practice consultant. And, she knew this dentist as well. And what we're just finding is that, she, because of her past and things that have happened in her life, she's very, very aggressive in her planning, very, very aggressive. So instead of watching those areas, she would like to go ahead and take care of them versus another dentist who just rather would keep a watch. So time is also a major barrier to calibration. If you are in an office where you are booked 3 or 4 months out, how do you carve time in your schedule to calibrate? Typically, when you're having office meetings, you're discussing schedules and other policies and how to move forward. But it could be hard, to ask someone maybe to come in on a Saturday, or you've worked a 5-hour day. I don't know who works a 5-hour day in here, but maybe you've worked a 9-hour day. And then to ask your staff to stay 2 additional hours to calibrate, that could be hard, especially when there's no value placed on calibration. And then last, we've touched on this already, you have the new graduate versus the seasoned professional. Do we have, okay, so Patty, when did you graduate hygiene school?
Well, did you want to talk to Patty B or Patty me? Patty me, 1973. Patty B, it was what?
Fine, it was 1969.
Okay.
50 years.
So I think it would be fair to say that we did not learn the same. I graduated in 1997.
Probably not.
Okay.
No.
So,
I went to. It was for a local anesthesia review course, and they changed some of the anatomic landmark names. That is not fair. That is just not fair.
So imagine, okay, so they changed the anatomic landmarks. You happen to be temping in an office with a new dentist, and he's a little squeamish about his hygienist giving anesthesia. So he says, okay, I'll let you anesthetize your patient for this scaling and root planing procedure, but I want you to walk me through what you're doing, and I want you to name all of your anatomical landmarks. Now imagine the horror on his face when you start to call out terms that you learned in 1969 versus the terms that he may have just learned in 2015. And that's happening in front of a patient. So what happens in that scenario is that he no longer trusts that you know what you're doing. And, behind the scenes, he could be having a conversation about you and questioning your ability. So I think if we are to or our office were to calibrate, especially if you're a new hygienist walking into a practice where someone's been practicing for 30 years, I think that would alleviate a lot of conflict, quite a bit of conflict.
If I can jump in here, I think, though, that it goes the other way, too, that there are new graduates that think they know more than they do.
Absolutely.
You come out and you really barely know how to scale when you first get out. It takes you, 3 to 5 years to even develop that skill. So this is where, again, it's the idea that one isn't better than the other, one isn't smarter than the other. We just have different experiences and different knowledge sets, and so calibration is really what can bring us together.
Well, I think you should take it to the other extreme. You get a hygienist who comes out of school and is working from a truly preventative model, and yet stuck in waiting till disease happens model, like this doctor who's more aggressive treating. I mean, think of that. You're all excited to do this preventative piece, and you get stuck in an office where they're still doing things the same way as 60 years ago.
Yep. Well, scaling root planing as a terminology is a 60-year-old terminology, so, our language needs to catch up, too. There's some calibration that needs to go happen.
Absolutely, but another procedure, full mouth debridement. We do not teach that in school. We don't teach it in school, but yet you walk in these offices as a temp, and they're telling you to do a full mouth debridement. And as a young hygienist, fresh out of school, wet behind the ears, what do? What do you do?
The other thing too, though, I think we have to be careful because not all hygienists that are graduating are young. There's a difference between, I think, a new graduate and a young new graduate. Because I know, and I don't know where it is, how it is in other parts of the country, but I know a couple of the programs around here where I am that fully half of their of the people that are in a hygiene program have a 1 or 2 degrees in another discipline. So some of our young old kind of thinking also, I think, could be problematic. There's one I just worked with again the school, and the educator that invited me to speak graduated from that program 3 years before. She's 64. She went to hygiene school at the age of 59.
Wow. That's
When
yeah, wow.
I went to school, though, we had older graduates who already had a bachelor's degree who came. That was 50 years ago.
Right.
I mean, it's
So
not
some of our
phenomenon. And then there's the people who graduate and never think a step beyond that and never want to learn anything new. And then there's other people who are 50-year graduates still learning new things. It's hard. First of all, you just can't prejudge by how old or how long they've practiced.
Right.
That's very true. That is very true. I was very young when I came out of school, and I remember, I think this was my very first temp job. I worked for a very prominent prosthodontist in Washington, D.C., and my schedule was 8 to 5. My last patient had a, roundhouse, so there wasn't a lot of deposit there. The patient came every 3 months, and, in school, you're taught never to use coarse prophy paste on any type of crown. So I didn't see any fine polishing paste, and so I polished very light. And I remember being reprimanded, saying I didn't do a good job. I needed to polish a little bit more. And I remember having to stand up for myself and say, hey, well, in school, we were not taught to polish with coarse prophy paste. And he took it upon himself to walk me around to the 3 other hygienists who were in the office to ask, what are we supposed to polish with? And thankfully, they backed me up and said, yes, she is correct. You're only supposed to polish with fine prophy paste, but we only have coarse in the office. So it's even things as small as that, where it could cause, I was very embarrassed. He did it in front of the patient. But I don't know, that's not a question that you think to ask walking into an office as a temp. What type of prophy paste do you have? And had we been calibrated ahead of time, we could have avoided that situation. So thank you for sharing. Next slide, please. I always love this quote. And I should just say dentistry in general. Practicing dental hygiene for 20 plus years does not make you a clinical expert. We all can stand to learn things, and as long as we keep an open mind, I think this will help to facilitate the calibration process. Next slide, please.
By the way, all great speakers put important quotes on there. I like that you're quoting yourself.
Thank you.
I was going to say, there's another one for that. There's another one that just because you're a hygienist who worked in a perio practice doesn't mean that you're a clinical expert. Thank you very much.
It's funny, when I did a calibration course for educators and I pulled that slide up, you could just see people's eyes. I mean, it was just like dead silence. You could hear a pin drop. And I said, I know that I'm stepping on some toes with this one, but it's true. It doesn't make you the clinical expert. It does not. But that's probably a whole other mastermind, Patty, for you to consider. I find a lot of the calibration issues in offices happen during the crossover exam. What do I mean by the crossover exam? Let's say you're in a practice with 5 dentists, and the dentist that you normally see is on vacation in Hawaii, so you get to see the partner. So it's dentist versus dentist. Okay, this dentist said, I want to do crown and bridge on 18, 19, and 20. This dentist says, absolutely not. I recently graduated, and I think that we should do an implant rather than remove additional tooth structure. Imagine what that patient could be thinking. And then you have the dentist versus the hygienist. The hygienist, new patient walks into the practice, the hygienist does a comprehensive perio exam, notices 7, 8, 9 millimeter pockets. And they recommend that, you know what, it's not much that we can do for you here. I think that we should refer you to the periodontist. Hygienist has already had the conversation with the dentist, and then the dentist comes in to do the exam and then says, well, hey, we're going to treat you here. We're just going to do 4 quads of scaling and root planing. What is the patient thinking? And then last but not least, you have the hygienist versus the hygienist. I know that I've worked in a practice with multiple hygienists, and I think I heard another participant say that she worked in a practice, was it with 8 hygienists? I can't remember who that was.
Jean, did you say that?
That was me. We have 8, there or 7 of us work on a day, but yeah. But
do you find that, and I think you may have touched upon this, but do you share patients, or do you pretty much have patients that stick with each hygienist?
Well, both. It's a combination. We share patients. No, so we see each other's patients. So yeah. It's kind of nice to get different eyes.
Different eyes, exactly. I've found that working in a practice with multiple hygienists can be hard. It can be hard for various reasons. Again, you know, someone's already stated that it really depends on where you went to school. East Coast versus West Coast, there are vast differences in the way that we are taught. But then it could also be, what was the philosophy of the school that you went to? And then you bring this into a practice, and now you're sharing patients, and you get into well, she thinks that she's better because she graduated, I'm just going to use phones, because she graduated from phones, but phones doesn't do this, they're supposed to be doing this. Again, imagine just the tension in the office. It's not always pleasant.
And Natalie and Teresa Shepard, who bears the brunt of all of these problems?
The dental assistant.
That's right. That's why I brought you forward on that one. So the rest of them are battling, and they're stuck in the middle of all of it. Yeah.
Patients feel all of that tension, and credibility goes right out the window with everybody.
Absolutely. That is key. Your credibility goes out of the window. Next slide. So this is one of my favorite pictures. I remember being in a practice, seeing the new patient, did my exam, comprehensive perio, x-rays, and told the patient, you know, you need, 4 quadrants of treatment. Got the patient to agree, patient is on board. Doctor comes in to do the exam, and can you guess what the doctor said?
Just do a prophy.
One other cleaning and you'll be fine. Yes. And so in my mind, I actually stepped out the office and probably went into the hallway and made this very face. I'm thinking, why? But this definitely happens. It happens all of the time. Next slide. My favorite is when the dentist tells the brand new hygienist to do something and she does what she wants. And I'm sure, I know even as an educator, when we are not all in agreement, this is my face a lot of the times at the end of a Friday, and I'm frustrated. The disagreement between a dentist and a hygienist is not pleasant for the patient, it's not pleasant for the dentist, and it's not pleasant for the hygienist. Can anybody give me a scenario where the dentist and the hygienist have disagreed, and explain how it affected the patient?
It confuses them.
So what's that?
It confuses them.
It does. It does. Do you have a particular story you would like to share? And I ask that you guys share the stories because it could help someone in their own practice if they were to encounter something similar.
Mine is exactly what you said. You know, I'm a pretty good communicator, and I would tell the patient, you know, their risk factors, what they found and what they need, and we'll say that it's scaling and replaning, possibly followed up by referral to the periodontist. And the doctor came in and the patient was asking, you know, it's a lot of money, and he hemmed and hawed. And he said, you know, it's really up to you, but we could actually do a perio maintenance and see where you look like in 3 months. And I said, well, and he left. And I said, well, we can wait till it gets worse if that's really what you want to do, or we can treat it now and move forward. And the patient moved forward. And so I just feel like in those instances, without throwing the doctor under the table, state your philosophy. And it's our obligation to let the patient know what's available and for them to make the choice, not for us to decide.
Absolutely.
Because we often do. We make the choices for our patient. And there's the whole risk benefits alternatives, I think, that we forget about. There are options. There are options. Now, sometimes the options to do something now or do something later, as Liz just said. Yet, I think sometimes we forget that we only see it from our own point of view, and having the patient involved in the decision making. Yet, even the tradition of the doctor coming in at the end of the appointment is the problem, is part of the problem. And nobody ever questions that. Why is it done that way? There's no, and yet supposedly a hygienist can't diagnose. It's a silly game we've been playing for years. And but so often we don't even question the systems that we're in. And that's the part, I think, for me, calibration is just thinking through all these different steps. And do they make sense? When they were decided, maybe they made sense, but do they make sense for what we know now?
Right. Absolutely.
There's stuff in the chat box. People.
Okay, who's talking in the chat box? I'm going to call on you now. The Patty told me. Renee, talk to us.
Sorry, Renee.
Hi. Comment
Renee.
on this. And just an example, too. I mean, I don't know, it was a while back. Well, it was not that long ago. But so maybe the dentists aren't up on certain things, such as myofunctional therapy and airway and all these different things that are current treatments that we're looking at, and I'm assessing tonsils and all this, and vault of the palate and all that. Oh, they're fine. You know, I mean, it's like, pull my hair out, you know? So I just, well, the dentist is, you know, so then I oftentimes say, well, you can talk to your doctor about this and see what they think, and usually a lot of times they have to go right to the ENT to really get a result, or to really find the information. And I said, you can self-refer there if you want. I've been doing a lot of research on this, and I know there's some new current information out there. I don't want to, like I say, you can't throw the dentist under the bus, and we never want to do that. But how do you encourage your dentist? I've given my dentist the TOTS book and articles, and just get exasperated on how we could calibrate this throughout the whole team, just to make changes.
Find someone that maybe teaches airway development and do a webinar with them and do a little team training and have that be your launch pad.
We even have a lunch.
There's multiple tricky ways that you can do it too. In the office that I worked in the last 13 years of my clinical practice, it was about as well. When I started there, if the patient had been in practice 28 years, I had a 28-year-old health history with pencil markings on the paper. Okay. Do I need to describe it further? Now, why did I work there? Well, we all decided what kind of professional we're going to be, and what happened over time is that I didn't go in and, oh my God, I lose my mind, because I've tried that technique. It doesn't work that well. But one of my techniques that I did, and this was, the way I worked it, is I saw that the doctor was interested in learning. I had him proof my articles that I wrote. See, I was giving him a position, not here, read this, you need to learn, but I was giving him, I respected his knowledge and said, hey, I need your help with reading this article. And what I'm trying to get to here is there's a lot of subtle ways that we can do this too. Because nobody wants to feel like they're stupid, as if they're old-fashioned or they're not. Yeah, and they're not. And they absolutely.
Sometimes they've forgotten what their philosophy is, maybe going back to what the vision statement is or the philosophy is and explaining how doing what you're doing ties into that and can only enhance not only for our patients' lives, but our productive life as well. Talking the talk about how it can also help the practice can usually help them move along if they see what's in it for them, right?
Absolutely. You start to talk numbers and they are all ears, always.
Well, yes, but I think we also have to be careful that the motivational set of every practitioner is money. Now, practice owner certainly has that because they got to sign the checks and they want to make sure that all of us get paid, and all of us here want to be paid, don't we? But that doesn't make it their motivational set necessarily.
Well, it helps. It helps.
It helps, but part of it though is understanding that person but not just bringing it always down to the doctor wants it to be more money. Because my experience is
I was basing it on that everybody wants it to be productive and that this is our philosophy. And I believe that if we start checking airway and talking about these things, we're going to be adding value to our patients, which in turn will help us continue to be that practice in the forefront by being able to buy new technologies or whatever you want to talk about. I think it's just part of the piece of the puzzle, not necessarily, the do or die.
Yep.
Absolutely. Okay, next slide. So what you find is that offices do have certain calibration protocols in place already. So earlier we talked about the needle stick policy. And the reason why all offices have a needle stick policy in place is because it's the law. But again, it's a guide. If something happens, we go to it and we're able to follow it. Second, most offices have a protocol in place for how things are to be sterilized. Now, some offices take it a step further and they actually have a manual. But for the most part, I think everyone is on the same page in terms of how should instruments be processed once they are finished or the practitioner has finished using them. There is a general understanding of how the operatory should be broken down and set up. Scheduling. Again, either there is a written guide, but for the most part, I know I worked front desk for a few years prior to going to dental hygiene school, but I knew that for a root canal it was an hour. I knew that, unfortunately, at the time, our hygiene appointments were 30 minutes. I didn't know any better. I was 16. But we scheduled maybe 45 minutes for post and core. So in terms of scheduling, let's just say most practices now either every dental hygiene visit will be 45 minutes or every dental hygiene visit will be an hour. But we're calibrated so that if anybody picks up the phone and a patient wants to schedule an appointment, if the office says we do an hour for a dental hygiene visit, then everyone knows that. Frequency of x-rays. Unfortunately, most people go based off what the insurance says. So we're going to take bite wing x-rays every year. We're going to take, if your insurance allows us, we're going to take a pan every 3 years or every 5 years. But again, that's a protocol in place. Fluoride treatment. What I'm finding is as an office, they either do or they don't. Most offices won't do it because insurance won't pay for it. But again, that's a protocol in place. But in terms of patient treatment, are there real protocols in place? For example, when should you crown a tooth and when should you not crown it? And I'm sure if we opened up the discussion that there are 15 attendees in the meeting tonight, we would probably have 15 different opinions. Now imagine if we were all 15 dentists working in an office and we shared the same patient. We have to give that patient the advice on when to crown and not to crown. That would probably be one confused patient. Next slide. So how do we develop a calibration plan for the office? I read an interesting article in the Journal of the American Dental Association. And what I found is that we could use ethical principles as a guide to calibrate the office. It's really, really important. Next slide, please. So the ADA and the ADHA Code of Ethics. There are some key aspects to both. I'm just going to touch on a few, but patient autonomy, justifiable criticism, professional demeanor, patient records, non-malfeasance, and veracity. These are some of the different principles that we can use to get everybody on the same page. This article talked about the ethical implications when staff are not calibrated, and usually these ethical applications affect your risk management. And I know we talked about that earlier, but also it affects the bottom line, okay? So the next few slides, we're just gonna talk about a few scenarios using these ethical principles and kind of show you how you can use them to calibrate your faculty. Next slide. Okay, so autonomy, that's the first principle, okay? When to scaling route planning versus referral. I know we keep going back to this, but this is an easy one for us to use, okay? So how should the dentist and the staff members best convey the periodontal diagnosis to the patient? Okay, so Patty, we just talked about this. Under both codes of ethics, the patient should be informed of what we recommend, but also any reasonable alternative. Okay, and we need to explain it in such a way that allows the patient to become most informed about what's going on. Okay, so how does this relate to calibration? Well, again, we have to say the same thing. Is the dentist going to say the same thing as the hygienist? So if you keep this ethical principle in mind, autonomy, okay, when we are presenting this information to the patient, okay, we are going to let them know this is what your diagnosis is. These are all of your treatment options. This is what happens if you do proceed, and this is what happens when you don't proceed. Next slide. Justifiable criticism, okay? It is not uncommon to have differences of clinical opinions in clinical practice, okay? So what does this ethical principle state, okay? This is more for the ADA Code of Ethics, but a difference of opinion as to preferred treatment should not be communicated to the patient in a manner which would unjustly imply mistreatment, meaning one dentist says one thing and you disagree, okay? If you are properly calibrated, okay, you are actually able to bring about a proper degree of consensus, meaning if there is that crossover exam, one dentist is not on one end of the spectrum while the other dentist is on another end of the spectrum, okay? In this scenario, I think when you have temporary hygienists coming into the office, I think it's important, again, I said what we say matters. We should write down concise statements on every type of treatment so that any member then can come in and be able to say the same thing to the patient. Next slide. Okay, so professional demeanor in the workplace, okay? We, ADA Code of Ethics states that a positive workplace, a positive, respectful, and a collaborative workplace should be provided, okay? So that goes back to not demeaning. You don't want to undermine the dentist, or you shouldn't feel like your position in the office is not respected. When an office is calibrated, it brings a sense of unity. Everyone feels important, and everyone feels like they are a part of the team. Next slide. Patient records and non-malfeasance. So we know that dental records should be maintained in a consistent manner, not only to protect us, but to protect the patient. So in an office, again, there's 5 hygienists. I can tell you that each of us wrote up our notes quite differently. Are you finding, those of you who work in a practice where there are multiple practitioners, is there a standard way that you guys are writing your notes, or is everyone writing something different?
We use a template, like that the doctors designed.
Okay.
With our we're paperless. We went paperless, and then they came up with it. So that helps within the guidelines. So
for me,
anybody
I like
using an SOAP format?
Pardon?
Soap notes.
Soap notes?
Cliff notes. Well, auto note, like an auto note, you mean? They kind of.
Oh, not an auto note. Auto notes very different. Soap notes it's a very common practice in medicine, as well as it organizes the information into a very specific protocol. From that, it's part of what I teach in my courses. From that, we can write a really good, concise, what I call Twitter style dental medical necessity. So that's what our notes need to contain. But I say Twitter style because I think many of us, I was one of those, that we would document. I thought the more was better, but it's not better if it's not readable. But by the same token, even in the CDT book, even the CDT companion, it specifically says it does not recommend using templates to create narratives, because what happens is then it becomes everybody reads the same. And even the dental benefits world are going, yeah, no, that doesn't work that way.
Yeah, that's a problem when I do audits. That's a very frequent problem, is over-reliance on the templates. And so just get cut and pasted, and they're identical.
I like to write novels. But I write a lot. I include a lot in my notes, and that was one thing. When I did do clinical, I was praised about. I write everything. And I find, unless someone is really going to take the time to develop a template where it forces you to change things, I myself am not a fan of templates. I know with my students, they like to do the copy and paste. And what I find with the copy and pasting is that they're not even changing dates. So I'm reading, well, this person was taking amoxicillin. Oh, okay. Well, it's 6 months later. If they're still taking amoxicillin, there's probably an issue that you refuse to address, or you simply forgot to change your notes.
Better look for some yeast growth. Amoxicillin. The thing of it is that when we write another thing, what direction things are going from a coding perspective, and I'm going to keep bringing it back to that, is that we now only have codes for treatment. We need diagnostic codes, but where things are going in the coding world is that everything will become codes. The idea of all these handwritten notes, again, whether they're electronic or not, if they're not searchable, if you can't measure anything from them, if there isn't a way to accumulate that data, we really miss things, because how much time is committed to not only writing everything that you're writing this time, but having the time to read it the next time. And usually, in my experience, there's no time that's set up for documentation. There's no time that's set up for reading it. Not really. Let's review the charts in the morning before the huddle. Yeah, do you sit back there and read all the last 5 to 7 years of history that you might have on that person? Not usually.
Right. That's so true. That is so true. I think that, there should be a uniform expectation of what is to be included in the patient's record of treatment. And that is actually going to assist people, other providers who see the patient subsequent to you or in subsequent visits, to understand the patient's course of treatment. And I think that goes to what you are speaking of, Patty, those actual, not treatment codes, but the diagnostic codes. And we know that this uniformity not only helps protect the patient, but it speaks to the ethical principle, non-malfeasance. We do no harm with proper record keeping. Proper record keeping, if there's a standard, we're even following it. So that is how we tie that all together. Next slide. Veracity. Okay. Telling the truth. Telling the truth. We as professionals have a duty to communicate truthfully. So let's take it back to a situation where you have two dentists. One is more aggressive and one is very conservative. Okay. I don't think either will intentionally say something wrong to the patient. But when you are over aggressive or you're underdiagnosing, are you being truthful to the patient? For the dentist who's aggressive, are you truthfully telling the patient that they could stand to wait, that they're not gonna, the teeth aren't gonna fall out if they, you know, happen to delay treatment 5 or 6 months? And for the dentist who's underdiagnosing, are you letting the patient know that, you know, for every time that we watch this, you are, you know, potentially exposing yourself to future problems? So a well-calibrated staff, they're going to be able to address all differences prior to patient care. Meaning, if there's a difference between the dentist and the hygienist, those discussions need to happen prior to the patient being in the chair. Okay. We find that you have clinicians that will only tell bits and pieces of the story. You have the new patient who comes in and says, well, I didn't go to that dental practice because, you know, I walk in and there's marble everywhere and their kids go to Ivy League schools. And every time I come in here, I have their treatment planning something. So I'm looking for a dental office that will only just clean my teeth. And so you're there like, well, although this person needs 5 crowns, I'm not going to say that because I don't want them to leave. So you do have cases like that. It's very, very important for our patients to hear accurate and consistent information from everyone in the practice. That's going to be key. Next slide.
So, but let me challenge this. And I know we're running late, over our hour, but I think it's well worth it, guys. Is that, okay, with this idea of veracity and truth, where is the thing where you just said, well, we're not going to throw the dentist under the bus? All right, okay, where does the truth then come out about how you feel about that practitioner? Is it also then, that's part of calibration is our communication, our calibration of our communication, and what that means to tell the whole truth. Does that mean if I think somebody is, you know, got a bad looking outfit, do I tell them? I think their hair looks lousy. You know, I mean, this is where it gets tricky.
It does.
Because where's the lines here?
It does. But I've even been in situations where I've had someone come from another practice and I just don't believe in throwing another hygienist under the bus. You know, they're walking into the office and I'm saying, hey, you need 4 quadrants of scaling and root planing. And well, I've been going to this hygienist for 20 years and she never told me. Well, I don't want to throw that hygienist under the bus. And so, you know, I've just gotten real creative in my language and explaining, you know, what may or may not have happened. And I try to not devalue someone else's expertise, but it gets really, really hard. It gets very hard. I have to agree with you there.
Anybody else have any comments on that? We've had a couple people join us. I think some East Coast people. Hi, Michelle Race. How are you? Say hello.
Hi, Patty. Good. Thank you.
Hi, dear. They also have the newest member, the newest insider in our insider network that just joined us, Eileen Fritzy. Eileen, say hi.
Hello. How is everybody doing tonight?
Hello. Good. And Eileen, you have an opinion or 12, don't you?
On a slow day.
Welcome.
Thank you.
All right.
Thank you very much.
Please join the conversation. So let's move forward then, Joy?
Yes, you may move forward.
All right.
Okay, next slide. Okay, so we're running short on time, but I'm just going to throw a few things out at you. So we kind of do this out earlier, but under what this would be a way to calibrate. You all are in the office and you throw out the question, under what circumstances would you perform a full mouth debridement? And I'll pose that question to the group. Under what circumstances would you perform a full mouth debridement? And I'm going to play devil's advocate just to get the conversation going. Anybody?
If you can't diagnostically probe or see caries.
Okay. Is there anybody that feels like there's no situation where there should be a full mouth debridement performed?
There are situations when somebody would come in and they haven't seen a dentist in quite some time. And so they have not seen the hygienist.
Okay, be more specific.
Well, they have a lot going on, and they're just going through their assessments.
Mm-hmm.
So
what's a lot?
They have decayed teeth, they have fractured teeth, they have periodontal issues.
Mm-hmm. What type of fracture do they have?
I'm sorry?
What type of fracture?
Oh, a tooth might be fractured, from a traumatic occlusion.
Mm-hmm.
And usually it's something in the front, and that's what brings them in. They want you to fix that one tooth in the front that doesn't look good.
Absolutely. Okay. So under what circumstances would you place a crown?
Well, in our practice too, it's a little tough because when somebody comes in with a mouth like that, and if you practice one tooth dentistry or single tooth dentistry, it's a problem because you're not fixing anything, and that tooth is going to break again or fail, and that gets in line too. I had a man come in the other day, and he's like, "Oh, well, I have $1 million mouth. Everybody sees a gold mine in my mouth. How do you start talking to somebody like that? I'd rather go on vacation." That's what they want to use their money for.
So is that wrong? And is it up to us to judge that he's wrong?
Very true.
Well, yeah, of course. But again, sometimes we have to meet them where they are and bring them forward. But then again, you have to all be calibrated on what you're going to say.
Absolutely.
Right. So one way that you can come up with a calibration plan, earlier in the conversation, I stated in your clinic practice philosophy, you need to list every single treatment that you provide in your office. And then you need to have verbiage on what you will say, how you're going to present it to the patient. One way to get on board is like what we just did tonight. Under what circumstances would you perform a full mouth debridement? And you need to be very, very specific so that if there's 18 hygienists in the office, no matter who comes into the office, you have those different scenarios written and you know how to approach it. Another good one would be, because hygienists, we know that we recommend treatment from our exam. Under what circumstances would you place a crown? Okay, so if someone says, we're going to do a crown if there's a large amalgam restoration. Okay, so what does large mean? Is it symptomatic? Is there leakage? Are the margins intact? You have to go further. You can't be surface. You have to really dig down deep and answer all of those questions, because the more specific you are, the more calibrated you will be in the end. Does that make sense to everyone? Okay, next slide. Okay, so when you are in the process of developing this calibration plan, it is important that at the end of the day, as best as possible, everyone is doing the same thing and saying the same thing. When you come together to develop this plan, it's important that everyone offers an opinion and state why they feel the way that they do. If everyone is given an opportunity to state their opinion and give their reasons why, then the office is going to be able to develop very specific guidelines on each procedure, okay? Other exercises that you can do would be calculus detection exercises, advanced instrumentation. My favorite would be the new periodontal classification, okay? Ultimately, a calibrated staff will increase patient compliance, satisfaction, and it'll have a positive impact on the office's bottom line. Next slide. Thank you. That's all.
Thank you so much, Joy. I really appreciate that you brought this forward. I think one of my experiences with this is it's the process of the calibration that really is the success. Because I will still remember in an office, we once spent 3 hours discussing the difference between effectiveness and efficiency. Those of us that were there, are we clear on that definition between us? But then what happened is we didn't end up bringing that forward when new staff came on. Because I think that's the other thing, is calibration is not a point in time, it's an ongoing process. Would you agree?
Absolutely. It's not a one time thing. I think that you should use every office meeting as an opportunity to calibrate on something big or small. And it doesn't have to be anything major. Again, what type of trophy paste should we be using and why? It really is that simple.
Yeah, for sure. For sure. So thank you, everyone. And again, I hope it's always discuss things. Remember, next month, it is July 23rd when our next mastermind is. This mastermind will be posted online and the insider site in the next 24 hours or so. And again, I really appreciate all of you, and text, email. If you didn't put your name in the chat box for the CE, you can. If you want to listen to this again or any of the others, all of that information is online. We're creating the future. We're not letting the future wait for somebody else to figure out the future for us. And I believe we're truly up to that task. So thanks, everybody, and have a really good night.
Thank you.
Thank you.
Thank you.
Bye.
Thank you.
Good night.